For this lecture, we will cover Chapter 11, the adverse complications of transfusion, otherwise known as your transfusion reactions. I'm going to go through and do this lecture, but just know that there is an assignment that also goes through each of these transfusion reactions that it will assist you and add to this lecture. Adverse transfusion reactions are basically an undesirable response or effect in a patient that is temporarily associated with the administration of the blood or the blood components. Now, about 10% of transfusions can have a negative effect, and there are a variety of ways in which that effect can be negative. It could be as mild as just a mild sensation of just feeling off or different, as far as it can be to the extreme of causing a severe reaction that could lead to death. Now, transfusion benefits should outweigh the risk, so you've really, the clinician needs to kind of evaluate the patient in the situation to determine if the risks are really worth the benefits that you will get out of the ultimate outcome. Now, most serious reactions do occur during or immediately after the transfusion, so it's very imperative that the patient is monitored during the transfusion and even after the transfusion to check for any signs or symptoms of a reaction. Now, clerical errors are the #1 cause of death for a transfusion, and that's just simply because of just not matching up the product with the patient, doing those clerical IDs, whether it's pre or post analytical, or as far as once the blood gets to the patient to be infused and it's infused into the wrong patient. So those clerical errors are going to be your #1 cause. Now, there are some risk of disease transmission and mortality that are associated with blood transfusions. Now, despite the fact that we do a lot of testing now on those donors before they're ever transfused, it involves a lot of different testing some of which is not listed here. So there is still a risk of someone being transmitted something through a blood transfusion, just simply because it could be that infection of that donor is in that window where it's not detectable yet on traditional testing. So there is still a window there of which the testing is not picking up on it, but the patient is still, or the donor rather, is still able to transmit that disease. So there are some things listed here. Of course, these numbers do change throughout the years. These are some older numbers here, but it just kind of gives you an idea of the frequency of the various transfusion reactions as well as the diseases that can be transmitted, and as far as what those risks are. But as you can see, your TACO, transfusion-associated cardiac overload, as well as your TRALI, or transfusion-related acute lung injury, do tend to be the highest frequency as far as causing any type of mortality or death for those individuals. Now, the nurse that is in charge of actually transfusing and administering that product to the patient has to be aware of the various signs and symptoms that the patient can exhibit when they are experiencing a transfusion reaction. And so most places do have a way of educating and communicating this information with the nurses. They do have to go through training of how to administer blood products and what they've got to watch for, as well as most institutes have some sort of form that they will use to document a patient's symptom, whether it's electronic or a handwritten type of form, but there is a way to document the patient's vitals and look for symptoms. And on that documentation, there usually includes additional information that will let them know as far as what symptoms to be checking for, in addition to the timing for doing those checks, as well as instructions of what to do if any of those symptoms do happen, as far as what the nurse should do as far as tending to the patient and ordering the testing and sending that to the lab to be worked up. But something that I want to mention is if there's a fever that's greater than 1 degree Celsius from that normal body temperature, or if it raises to above 38 degrees Celsius, or if there's a 2-degree increase for Fahrenheit. So it's 1 degree for Celsius, 2 degrees for Fahrenheit, as far as what you're observing, to look for the possibility of a fever. And then the rest of these are pretty much just symptoms that the patient's going to kind of exhibit, or maybe you're going to catch it doing those blood pressures and things like that. Now, your transfusion reactions can be divided into a couple of categories and then further subdivided in those categories. So you have acute reactions. Now, these happen in less than 24 hours of that transfusion being implemented. And your delayed transfusion reactions are going to be greater than 24 hours. And then within those categories, it can be further divided down into immune-mediated versus non-immune-mediated. And so with those immune responses, you're going to have some kind of antigen antibody attack and destruction that's taken place. Sometimes it's going to be a hemolytic type of reaction, and sometimes it's not. So we're going to kind of further talk about these transfusion reactions here. Okay, so some of your more common ones are going to be febrile, allergic, and then of course those antibody production through alloimmunization. And then some of your less common are going to be your circulatory overload, as well as your delayed hemolytic transfusion reactions. Then some of your unusual types are going to be your immediate hemolytic transfusion reactions. You know, typically you're not going to have these because you've done all your checks and steps that should be involved as far as preventing any kind of reaction that would happen due to or immediate reaction that would happen. Anaphylaxis is going to be more of your unusual, as well as bacterial contamination, and then graft versus host disease. Now, there are errors that can lead to a transfusion reaction. These are going to include things like misidentification of the patient. So this could be during collection, or it could be when you're actually hanging that unit ready to transfuse. There could be errors with the sample as far as collection and labeling. The wrong product is actually issued, transcription errors, errors while administering that product, technical errors that can happen behind the scenes, as well as storage errors that can happen. Okay, so allergic reactions, these are caused by soluble antigens in your donor plasma. So it's the plasma products that are going to cause these type of reactions. Now, keep in mind that your red blood cells do have a very minimum amount of plasma in there, so that's not to say that you will not see an allergic reaction in a red cell unit. It's just going to be more associated with those plasma products. Now, an allergic reaction is just going to be an IgE type of reaction with those plasma proteins. So with that, it's usually going to be more mild, where you're going to have those rash and hives, whereas your anaphylactic type of reactions, these are going to be due to antibodies to the IgA, and this is going to be a more severe type of reaction with this anaphylaxis type of reaction, and it's going to be a more systemic response throughout the entire body that's going to kind of respond to that product, or those IgA antibodies that are present. So they're actually antibodies to the IgA. Now, with your allergic reactions, you typically are going to have the absence of the fever. I have seen cases where you see allergic reaction in addition to the fever, but usually if you're going to see the fever, it's due to the underlying condition. It just happens to be associated with the reaction at the time. So just kind of keep in mind that when the body is going through that response and it's trying to fight off and figure out what's going on, it's not typical to see the fever, but occasionally you can see a fever. But ultimately the physician, pathologist, is going to be the one to make the call on what the type of reaction is. Okay, so just kind of comparison. There's a nice chart in the book that's just going to kind of compare the allergic versus the anaphylactic type of reaction. Of course, you can see with the anaphylactic, the clinical signs and symptoms that are going to present are a little bit more severe with that rapid onset, the breathing difficulties, the bronchospasms, and things like that. With your anaphylaxis, it's going to be more of your major complication. Typically with your allergic, it's pretty treatable as far as treating the symptoms, pre-medicating, antihistamines, things like that. With your severe anaphylactic type reactions, it can lead to shock, loss of consciousness, as well as death. So it's very important that whoever's administering the product, that they're aware and watching for the symptoms that can happen. If any sort of allergic type of reaction is suspected, of course the transfusion is going to be terminated immediately. Depending on the severity of it will depend on the treatment from that point on. It could be as mild as an antihistamine like Benadryl, or even administering something like epinephrine, as well as kind of treating those symptoms. And as far as prevention, once a patient is known to have an allergic reaction, then it's always going to be suggested to pre-medicate that patient with some sort of antihistamine before you actually give that product. And then with a patient that has a history of anaphylaxis, then your plasma-containing products from an IgA deficient donor may be necessary, as well as using washed red cell and platelet products. Now, your febrile non-hemolytic reactions, so this is going to be happening when there's a fever that's present. If that happens, you need to have the clinician stop the transfusion and medicate with some sort of pre-medication. They typically will do something like Tylenol. Sometimes they'll recommend Tylenol and Benadryl, just for that extra little caveat there. Check for clerical errors in specimen hemolysis, culture, and gram stain the bag, or as well as the filter if there's any sort of like liquor reduced filter or anything attached as well. The nursing floor does usually have some sort of blood filter that it kind of runs through as well, just to kind of remove any microclots that may be present. Culturing at a variety of temperatures. So typically the micro department is going to have procedures in place for what to do with blood products that they receive for culture. If those cultures do come back negative, or that gram stain is really going to be what's going to give you your preliminary reports, with those patients, they are probably just going to receive liquor reduced products in the future, or possibly HLA match, just depending on what's determined as far as the outcome. If it is suspected that that patient is having a more severe type of febrile reaction, it may be recommended, just based off of their condition, to provide HLA matched in the future. Hemolytic transfusion reactions. So these are very serious. They are the most serious of the reactions because they can cause DIC, renal failure, shock, or even death. Symptoms are going to include fever, chills, chest pain, hypertension, hypotension, shortness of breath, anxiety, nausea, lack of urine or decreased urine, as well as blood in the urine. When the symptoms are noticed, of course, you need to stop the transfusion, keep the IV line open in order to be able to administer any sort of fluids or medications that may be necessary to treat that patient, as well as you want to continue to do those blood pressure checks, monitor for signs and symptoms of renal failure. They're going to be observing that urine to see if there's any changes in the color. Maybe perform any sort of coagulation testing, checking for clerical errors. And of course the blood bank is going to do their part as far as the pre and post transfusion testing. That's going to include DAT and other testing. So with the DAT, we're looking for that in vivo coating of those red cells. Now, our hemolytic transfusion reactions, when you do the DAT on the post sample, you're usually going to see some sort of mixed field reaction, because you're going to have that incompatible product that is being coated for destruction versus the patient's own cells. Hopefully they're not being coated with anything. Now, the DAT can be negative if the specimen is drawn several hours after the symptoms happen or start. And this is because those red cells are already being marked and labeled for destruction. So the body will spend that time actually destroying those cells and trying to remove them. So it's very possible that you could get a negative type of reaction on that patient. Additional testing that is typically going to be done in the blood bank for any transfusion reaction, but more specifically the hemolytic, will be repeating that blood type and antibody screen, as well as repeating those cross matches. And of course, you're going to do this in the pre and post samples just to see if there's any difference in the testing before the transfusion versus after the transfusion. You're going to be looking for hemolysis, so you're going to kind of compare that with the pre and the post sample. And you're also going to have a urine sample in which you're going to look for signs of destruction that's spilling over and being evident in the urine. Additional testing that could be ordered as far as monitoring or checking the status of the patient as far as their clinical condition and presentation. You could do things like haptoglobin, LD, bilirubin, CBC, PT, PTT. So just kind of monitoring the patient with those lab values. Now, the non-immune hemolysis symptoms, these are going to include things like a high temperature, fever, or freezing with a low temperature. Typically, it's going to happen because there's some kind of mechanical issue that's causing that destruction. So something like a mechanical valve or a pump that's actually causing the destruction of those cells. So you're actually seeing signs of hemolysis that are going to mimic a transfusion reaction, but it's really just the mechanical parts that are destroying those cells. Bacterial contamination. Now, the major sources for bacterial contamination are going to be that it was possibly transmitted from the donor themselves. Maybe the donor had some sort of early stages of bacteremia that they were unaware of, improper cleansing of the donor's skin during the collection, or some other system failures, like there was a micro hole in the bag that wasn't noticed, or that was through like the collection port or entry or somewhere like that, where you didn't notice any kind of leak during storage, but that blood was contaminated while it was collected. There are some organisms that can actually grow at lower temperatures, so just depending on what the product is and how it's stored, there are some possibilities of some things that can grow. With your platelets, of course, your platelets, random and apheresis, will need to be tested for possible bacterial contamination. And that's simply because there's more organisms that can grow at that room temperature, like your Staphylococcus or your Bacillus. So testing those things before you actually transfuse them, as far as the platelets. So there's usually, each facility will have some way to do bacterial contamination testing for platelets, whether it's via pH testing, some sort of bacterial antigen testing type of kit, where it would be something similar to a serology type kit, where you're basically looking for those positive and negative lines for gram-positive and gram-negative bacteria. Or it could be some type of culture system where an aliquot is put into a blood culture type machine, and it's monitored for so many days looking for that bacterial contamination. Acute hemolytic transfusion reaction. So remember, acute is going to happen pretty quick. So when you think about acute, you think of acute like a baby, small, so you think about a smaller time frame. So that's going to be your less than 24 hours for that red blood cell destruction to take place. Signs range in severity, so it can be anything from like fever all the way to as severe as death. It's usually going to be due to an ABO incompatibility. So when you get those rapid transfusion reactions that happen pretty quick, and you've got that destruction and hemolysis that's pretty evident, it's usually going to be due to some sort of ABO incompatibility, which means probably there was some sort of clerical type error that took place, or identification that wasn't performed properly. Now, as little as 10 mLs of incompatible blood can actually produce symptoms. So that's why there is that process of observing the patient within those first few minutes of that transfusion starting, just to be able to kind of stay with them and monitor them, since a very small amount of blood can actually initiate a response. Now, there are some consequences that can happen from an acute hemolytic transfusion reaction that include things like hypotension, DIC, irreversible shock, as well as renal failure. All right, so the pathophysiology of those acute hemolytic transfusion reaction. So basically what you're going to have happen is that antibody is going to bind to those incompatible red blood cells. Then complement is going to be activated. It's mostly going to be IgM mediated, which is going to cause that intravascular hemolysis. So this is where those ABO incompatible products are going to they're going to kind of poke their head up pretty quick at the start of that transfusion. Then you'll have phagocytes that are activated, and then they're going to release those cytokines. And then from there, coagulation is going to be activated, and then possibly going to initiate that process of a DIC type of response, where the patient's going to start oozing from some areas, but throwing those clots in other areas. And then ultimately it can result in shock and renal failure. Now, there are some errors that contribute to a hemolytic transfusion reaction. I'm not going to go through all of these, but of course, any kind of clerical type errors in the collection or the processing or working up that patient can cause problems, as well as other issues that can happen as far as in the transfusion process. Let's just say pre-printed sample labels. This is another one, is people trying to get ahead of their workday and pre-printing all of these labels ahead of time, and then trying to divide them out, and then accidentally putting the wrong label with the wrong specimen number. So just, mostly just kind of not paying attention to what you're doing, confusing patients with similar names. So basically most of all of these are just basic simple errors that can be prevented just by paying attention to what you're actually doing. Okay, so your delayed hemolytic transfusion reactions are just as they suggest, they're delayed. So it's going to be a little bit more than 24 hours from the time of that actual transfusion taking place. They're less severe than those acute hemolytic transfusion reactions. And this is, even though they're less severe, they may be a little bit harder to catch, because sometimes you may transfuse the patient and then they go home, and then a few days later they start seeing symptoms. So that's why it's very important to educate patients as well, once they're transfused, of signs and symptoms that they need to watch for. They need to watch for that urine color changing and things like that. These types of reactions are usually due to IgG type of antibodies that are formed from some sort of prior exposure to those red blood cell antigens, or through some sort of pregnancy. And then those antibodies can go undetected during the pre-transfusion testing due to them being present in very low titers. And then once that transfusion takes place and they're stimulated, they're going to start back that response. Just like you've learned about your kids, they like to play. They kind of hide, and then you transfuse your patient, and then they decide they want to stick their head out and start playing, and then cause those hemolytic transfusion reactions, or those delayed transfusion reactions. Now, typically you're going to see these delayed reactions happen within a few days, but you can see them to several weeks after a patient has been transfused. Now, your textbook does have a great little chart that just kind of compares the acute versus delayed hemolytic reactions, and it kind of compares them on the basis of their symptoms, how they're going to present, as well as some of the major complications. So you can see, obviously, with your acute hemolytic transfusion reactions, it is more severe because you do have the risk of that DIC, renal failure, shock, and even death. Whereas with delayed, it's basically just going to be that red cell destruction over time. And so it's going to be more of the anemia versus any of the other more major complications. And of course, your acute's typically going to be due to ABO compatibility or some sort of complement activation, whereas your delayed is going to be more of a response to those alloantibodies. And as far as like management and things like that, you're basically going to, with your acute, you're just going to kind of monitor and treat those symptoms that are taking place, as well as, you know, try to avoid whatever potentially happened to cause that error, whether it was clerical errors or whatever. And then as with those delayed transfusion reactions, of course, working it up and trying to figure out what that antibody is and providing those antigen negative units for that patient in the future. Now, your non-immune hemolytic anemia, this is again when you have that red blood cell destruction that's taking place. There could be other causes. So we talked about it kind of being due to like a mechanical type issue. But there's other things that can cause that hemolysis of those red cells. So it could be that those red cells are exposed to extreme temperatures. So let's just say, for example, your units are put on ice and for storage for a trauma case or for a case in the OR, like a open heart surgery CABG patient. And someone inadvertently or makes an error in packaging those products. You're supposed to put a barrier between the actual red blood cell unit and the ice layers that you use. But let's just say that that barrier is not put there and that ice laying against those red blood cells causes them to actually lyse open, just like you would if you were doing that Louis Freeze technique for your red cell, trying to rupture those red cells to test for any kind of attached antibodies. Well, it's kind of the same effect. Those red cells get ruptured from the extreme temperature of that ice. Or you could have the opposite. You could have that unit get too hot. Maybe someone lays it on something that's warm and it heats up those red cells and destroys them. So obviously, if you infuse a product where the red cells have been destroyed, that hemolysis is going to be infused as well. There are some other things as far as the processing of the unit that can destroy those red cells. Using saline solution that's not a physiological saline type of solution. Of course, bacterial contamination in the red cell products can cause those red cells to be destroyed, so you can create some hemolysis there. And then, of course, intrinsic red blood cell defects can also cause some hemolysis. Okay, transfusion-related acute lung injury, otherwise known as TRALI. With TRALI, you're going to see signs and symptoms that are very similar to the ones that we've already talked about, like fever, chills. But what's going to kind of stand this out more is just the fact that you're having more lung involvement. Because again, as the name suggests, there is some lung injury that is taking place. So when the patient starts complaining of shortness of breath, you're starting to see some bluing of the skin, the lips, things like that, and then they have that non-productive cough and you're starting to see symptoms of that bilateral pulmonary edema, then that's going to be suggestive that you've got a TRALI type of reaction going on. Now, onset's usually going to be within 6 hours of that actual transfusion. Now, the complications of this can be very severe and even life-threatening. Now, the exact mechanism is not really, as far as like how the lung is actually injured, is not really known, but they're currently thinking that it's either basically a result of two events. You've got one happening with the recipient's actual underlying condition, and then the second is the actual transfusion itself. So basically, you've got a patient who's already compromised in some way, or else they would not be needing a transfusion. And then you have the donor that potentially has some kind of history of a pregnancy or anti-HLA antibodies or anti-human neutrophil antigens and some of the other biological response molecules that are taking place. And then those two are actually kind of coming head to head and causing this reaction to take place where it actually attacks the lungs. Now, we typically think of plasma products from someone that has had some kind of exposure and potentially has made those HLA type of antibodies. And so what happens is those infused antibodies to the leukocyte antigens will actually activate the neutrophils that are in the pulmonary microvascular areas. And then those activated neutrophils will actually cause damage to those epithelial cells in that lining. And then you'll start to have capillary leakage that will ultimately lead to pulmonary edema. Now, they have tried to reduce these risks by using plasma just from male donors or non-pregnant females. Some institutes have just implemented no female donors will be used at all for plasma products, just because, you know, there are situations where a female could be pregnant and not really know it and have a very early miscarriage and just think that it's a 1 or 2 day late period. So most institutes have kind of gotten away from using females altogether for their plasma products. Transfusion-associated circulatory overload. You may hear some people say transfusion-associated cardiac overload, but it's kind of fun to say because we call it a taco. But basically what happens is the patient's cardiopulmonary system has exceeded its volume capacity. So when this happens, when you've basically put too much volume into that patient, you think of it as a volume overload, which you may hear it referred to as a volume overload as well. When these patients have all of these things going on, they're getting IV fluids, they're getting red cells. If they're already kind of weak anyway, then it's just going to kind of aggravate the whole system in general, and then they're going to start showing symptoms of congested heart failure, which is going to be that difficulty breathing, severe headache, edema. You're going to see elevated BNP in your lab work, and then you're going to have evidence of that heart actually being stressed and going into failure, as well as having that pulmonary edema. These patients are going to be treated with oxygen therapy as well as diuretics. So the main thing is trying to get that volume off. Patients who are susceptible to circulatory overload, usually with those patients, what they might do is do a slower transfusion rate, or maybe even possibly giving smaller units. So they may divide that red cell unit up into 2 bags, and maybe instead of infusing the one whole product over 4 hours, they'll divide it up and they'll do half of it over 4 hours and then do the other half over another 4 hours. So they'll just kind of draw out that transfusion. But trying to do the red cells themselves and just avoid that excess fluids, you know, any kind of plasma products, anything like that, that you can kind of just lower that volume. Graft versus host disease. So with this, you're going to see the onset within 3 to 30 days after the transfusion. Patient will start with the fever, a rash, abnormal liver function, diarrhea, pancytopenia, and then from there the bone marrow can go aplastic. They can actually start to hemorrhage, and then there's about a 90% mortality rate. Now, what causes graft versus host disease? So this is when you've transfused an immunocompetent T lymphocytes that will actually mount an immunological response against the recipient. So it's actually the donor white blood cells or T lymphocytes that will actually start the response. And then from there, laboratory testing can be done to kind of confirm by HLA typing, which will demonstrate a disparity between the donor lymphocytes and the recipient's tissue. These patients can be unresponsive to any sort of medical intervention that happens. But to prevent any sort of graft versus host disease, of course, you could irradiate blood products to damage those white blood cells that are in there before you transfuse anyone who's going to be at risk. And then that gamma radiation, we've already talked about this in previous lectures as far as like how that's done against those donor units or those donor lymphocytes. So what the irradiation does is it actually eliminates the ability of those leukocytes to replicate, and then therefore it stops them from actually eliciting any sort of immune response. Now, depending on what the situation is, will depend on whether or not leukocyte-reduced products are needed. It's not indicated in your patients like that you think it would be, as far as patients with HIV, infants who are actually full-term, and your non-immunocompromised patients. So you may occasionally, though, have physicians that will request a product to be irradiated for those. If that's a situation, you might have to take it to pathologist, because that irradiation procedure, again, it shortens the date of the product, as well as it's a very expensive procedure. So if it does not need to be done, you really want to avoid doing it. But you're pretty much just going to do those irradiated products when you're dealing with premature infants, or infants that are still in utero, as well as directed donations, or if you have a patient that is suspected of needing any sort of HLA matched or is going to be at risk for graft versus host disease. Hemosiderosis, this is when you have an accumulation of excess iron in the macrophages of the tissue. You're usually going to see this with patients that are getting long-term transfusions, for example, like your thalassemia type patients, your sickle cell patients, because they're getting those multiple transfusions. That iron intake actually exceeds the daily excretion, and so what they'll actually do is start building up that iron. And so in order to prevent that, they might actually need some kind of iron chelation to remove that. Citrate toxicity. So this happens when you got a large amount of citrated blood products that are transfused. And so when that happens, these patients can have impaired liver function, preterm infants with hepatic or renal insufficiency if they're transfused a lot of products. So to prevent it, you remove the plasma that contains the citrate, or you can inject a calcium chloride or calcium glutamate type of treatment. Post-transfusion aprasia. So women negative for platelet antigen P1A1 are sensitized through multiple pregnancies, and then that will cause them to produce the anti-P1A1 antibody. And so some of the signs and symptoms that we see with this is the platelet count will actually start to decrease 5 to 12 days after the transfusion. Then you'll start seeing the purpura as well as some bleeding. To treat this, you can do plasmapheresis, exchange transfusion, or IV-IgG. Now, the procedures that we will do, or the staff will do, the medical staff, nursing will do, if they suspect any sort of a transfusion reaction, of course, you're going to stop the transfusion, keep the IV site open with the saline running. You're going to perform all of the clerical checks and IDs again at bedside. You're going to contact the physician, as well as continue to monitor and record the vital signs of that patient. You're going to alert transfusion services, and then they are going to collect that post-transfusion sample, as well as take the bag, including the IV fluids, the filters, anything that's attached to that bag that's going into that patient. All of that gets sent back to the lab. And then the lab will do their workup and determine if they can dispose of that product. Because remember, we have to keep track of partial units. So if that unit, even if they've infused it all and they've tossed that in the trash, they've got to dig it out. If the patient reacts an hour after, they've got to dig that bag out and send it back, because we've got to culture just to make sure if it's pointing towards a possible bacterial contamination, we still got to be able to culture that unit. Measures that will prevent a transfusion reaction, of course, the proper storage of those red cell units, not heating them up, not getting them too cold and freezing them, making sure that that identification of the donor and the recipient are accurate. If it's not, you do not transfuse. Never sign a blood product out just with a name. So if they come down and just have the name written on their issue slip, you've got to make sure they give you more information. You need the date of birth or whatever your hospital uses for that identifier, your blood bank number, your medical record number. Medication cannot be added to that transfusion. Follow the procedures for issuing those components. So those procedures as far as doing those clerical checks, inspecting that unit, doing all of your checks that are required, and following the protocols for specimen collection, labeling, and testing. Now your post-transfusion workup, it's going to include clerical checks. Did any sort of clerical errors occur? Was identification properly made? Was a sample the correct sample? You're also going to do visual checks. You're looking for hemolysis or icteric. You're going to do this on the blood sample as well as you're going to look at the urine. DAT testing. So you're always going to do a DAT test to determine if those cells have been coated with any sort of IgG antibodies or complement. You're also, depending on your lab and what their protocol is, typically you're always going to do a repeat blood type. Antibody screen may or may not be requested, doing a cross match again and repeating that with pre and post samples. Checking the hemoglobin and hematocrit, just kind of monitoring to see if there's a continued destruction going on. Looking at the haptoglobin and the bilirubin, as well as looking at the urine for signs of hemoglobin, and all of this is going to indicate there's a hemolytic transfusion reaction or a hemolytic type of process going on. You're going to do inspection of the unit again, making sure that you're not seeing any kind of hemolysis or bacterial contamination, and possibly doing a gram stain and blood cultures looking for bacterial contamination. Records and reports. Of course, transfusion reactions always have to be recorded and documented. Records of the patients that are experiencing the adverse reactions, those will remain on file indefinitely. So usually your transfusion services has a way to maintain these records for an extended period of time, whether it's electronic or hard copy. Cases of transfusion-related disease or bacterial contamination are reported to the donation facility. So if there's suspected that there's bacterial contamination or another issue, you've got to alert that facility, because remember, they're making multiple products off of these donations. So if there is a possibility of bacterial contamination, then they need to be able to pull those units and alert whatever facility has those units. Fatalities, if there's a fatality from a blood product, that is a reportable event, and so it should be reported to the FDA as far as if those reactions take place, and there's usually a policy in your blood bank as far as reporting those and how to go about that.